chronic. The acute renal failure, you're going to see it in people's charts that say AKI, acute kidney injury, acute renal failure, ARF is how you might see it written. It all means the same exact thing. It's how the doctor looks at the diagnosis. Chronic renal failure might say CRF or chronic kidney disease, CKD. These are abbreviations you're going to see that are acceptable in people's charts, and you're going to need to look at it and analyze, okay, this is what this person has. If somebody's in chronic renal failure, you're going to want to pay attention to what phase are they in that chronic renal failure. What's their GFR, glomerular renal filtration rate? Are they on dialysis? Are we making plans for dialysis? What's the risk factors that they're in chronic kidney disease, and how far along in the process is it? Do we say that we can reverse chronic kidney disease? No, it's not fixable. We just try to keep it from getting reversed. This is all stuff we talked about the other day. For the test, acute renal failure, you need to know some of the causes, and don't just tell me dehydration. There's lots of different causes. So is it a pre-renal cause? Is it an intra-renal cause? Is it a post-renal cause? Make yourself some note cards. Try to apply that. Don't just memorize, but when your question on NCLEX is about kidney disease, what created it? Okay, that's going to guide you to how we treat it. Is it because the patient's bleeding? Let's give them blood. If the patient's dehydrated, let's give them fluid. If the patient was on NSAIDs, stop the NSAIDs, right? Everything that we talked about the other day. What's our reasons? There are how many different phases to acute renal failure? Phases, not causes, but phases. 4. What are those phases? The onset, the patient's diet, then they're diuretic, and then recovery, right? That's all in your packet. Don't just memorize that, but what's happening in each phase that's going to change what I'm doing as a nurse or what I would anticipate the doctor order, right? That's what acute renal failure is. One of the first things that you need to recognize about acute kidney injury, always figure out why it happened. Why did it happen? What's the cause? And then it guides us to how we treat it. So if it's trauma and the kidneys were damaged, well, then we better get the patient blood if they're bleeding. Or we better take out the one kidney that's severely damaged. Acute kidney injury is not a hypertension patient that's had kidney disease for years and years. That's your chronic renal failure patient. So there's two different things happening here. This is acute renal failure. Something has decreased the blood flow to our kidneys. What supplies our kidneys with oxygen and blood? Our renal arteries. Not a vein. I think there was something on the side of the packet that said which vein supplies, and that should have said which artery. Each kidney has a renal artery. There's a left renal artery, a right renal artery. Understand for the exam, what are some of the tests that people are going to have done for their kidneys? What's a KUV? That's an X-ray, right? I'm just trying to help us remember the stuff we talked about last week. So we recognize if the patient's having a KUV, no dye, right? No MPO, none of that stuff. We're just looking at their kidneys. What can we tell from a KUV? Do they have kidney stones? Do they have a tumor? There's something abnormal there. Is there some mass of some type? Is the patient bleeding? But what more is a better test? Probably a CAT scan. Look at their abdomen. Look at their kidneys. If the patient's getting an IV pyelogram, what are we thinking right away with those kinds of tests? Dye. What's their allergies? Shellfish, iodine. Be prepared to have epinephrine available. Those are the things that every time you have a test question on NCLEX about a procedure, think about what the procedure involves, and then what's my preparation, what's my education, what would be okay for that patient to say or do afterwards. So here's our acute renal failure. Anything that damages our kidneys, stops blood flow, and again, quickly we'll go through the phases. There's an onset. This is what happened. It can last for, it can be hours that this is happening. It can be a few days that the patient's taken NSAIDs and that they don't recognize that it's messing up their kidneys. What are the antibiotics that we said are damaging to our kidneys? What's the category? Aminoglycosides. That's how you say it. What are they end in? Myosin. Everybody okay with that? So don't forget, okay, we're all aware now about NSAIDs, but myosin drugs as well affect our kidneys. Streptomycin, vancomycin, erythromycin. Keep that in mind. We have to recognize groups of medications that are going to affect different body systems. Does it mean somebody can't take those medications? No, it does not mean that. But if you know they have kidney disease, You wouldn't pick that, you wouldn't anticipate that, right? You pick something else. If you know that the patient, all of a sudden, their VUN and creatinine are going up because they had a wound infection, and we started on the streptomycin, and now their kidneys aren't working, what would be our answer? Anticipate the doctor change the antibiotic. Everybody with me? This is what we've got to be like thinking about. What are these meds do? So here's our acute kidney injury. Onset is, let's figure out what happened. Is it because the patient hasn't been drinking? Is it because the patient has not stayed hydrated? Is the patient had diarrhea for 7 days and now they're dehydrated? What's their specific gravity? Those are the things that we're going to be thinking about. So now they have a phase where they're not making urine. What are we going to do during that phase? Well, we're going to monitor the potassium. We're going to be giving them Lasix, a diuretic, right? We're going to be giving them IV fluids to kind of jumpstart their kidney in hopes that they get through this phase and then get to the diuresis phase. Everybody with me? This is our treatment. This is what we're going to be doing. So now diuresis, large amount of fluid starts developing from our kidneys. Now we're going to slow down the diuretics that we're giving the patient. This is indicating that the nephrons are recovering. This is what's happening. Specific gravity is now going to come down. It was high, now it's going to come down. What do we think might happen with lots of diuresis? We have to monitor blood pressure. This is the same exact thing we do for our chronic renal patients. We go to dialysis, when they come back, we monitor their blood pressure because it can be lower. What can happen now with our potassium? Instead of it being up, now what's happening? A lot of diuresis is going to go down. So we have to keep all this in mind. These are things now that we have to recognize are happening. And again, you could study these PowerPoints all day long, but you got to understand the concepts. And then how long does recovery take? Could take. Depending on how severely damaged your kidney was. Can we live with one kidney? Yes, absolutely. Can you live without either kidney? No. Now you're going to be on dialysis because you have to have your kidneys to do all the filtering and removing the waste products for your body. So here's our 3 types of renal failure. Look at each one of these things and figure out in your head how did this happen? What does it do to my kidneys? Recognize that drugs are usually in this category, but NSAIDs are pre-renal. We already said that because they decrease blood flow, and post-renal is the kidney stone, the prostate, some kind of obstruction. So we already went through all these different causes. Recognize for your kidneys, VUN and creatinine, that's your test. That's your kidney function test. Know what normal numbers are. Understand that if a patient has kidney disease, they're anemic. What do we want to give them? Erythropoietin. Pick that. That means it helps stimulate red blood cell production. I hope that everybody's like, yeah, okay, I heard this before. Why is she saying it again? I'm just trying to help us remember. Okay, so if you have an ABG question and it's a renal issue, it's not a respiratory acidosis. Everybody recognize that, right? It's not a respiratory issue. It's a renal issue, so that makes it metabolic. What happens? Metabolic equal. It doesn't change. So the pH goes down. Where does the bicarb go? Down, right? Everybody with me? Do we understand what I'm saying? Respiratory, the pH goes down, where does the CO2 go? Up. Okay, everybody, that's how you're going to get an ABG question. Simple as that. Don't make it too complicated. If you get an ABG question, guess what it's going to be? 2 or 3 sentences, and you're going to say, oh my God, how am I going to get this? Figure out first, what's the pH? Start there, and then move from there, right? Look at the bicarb numbers. The higher is the low. 35 to 45. And all those numbers got to be in your head. You're not going to have a scratch piece of paper control. You're going to have a board, right, that you can write your stuff on, or it's in your head, one or the other. And look how many numbers we got to have either in our head or write them on that board, and we can go back to the board, and that's it. You're not going to walk in there with anything. You're not going to walk in there with your Apple Watch. You're not going to walk in there with anything in your pockets. Nothing. So you got to, that's what's going to be in your head. So you guys will be fine because we've heard it so many times. So again, what's my UA going to look like if my patient has renal issues? Again, treatment depends on the cause. IV fluids to get to that diuretic phase. Diuretics in the beginning when you're in the oliguric phase. Your potassium might go up in the oliguric phase. What's the medication we're going to give if the patient has a high potassium? KX-late. What's the name of it? Polystyrene something, right? Sodium or something? 2 words.
Sodium polystyrene.
Polystyrene or something like that. That's K-X-late. That helps bring the potassium down, not up, down. What would we pick in order to give them, to get their potassium up? Potassium chloride. Don't pick in any NCLEX answer, I'm going to push potassium chloride, right? Patient's dead now. That's not a good death. So again, recognize we can give potassium chloride, but it's got to be in the right route that we're giving it in the right rate. Okay, so what happens with our diet for a renal patient? What do we want to do? An acute kidney injury could be high protein. That's okay. Why? Because they're healing. Something happened to their kidney to create damage. If it was trauma, infection, or whatever. What do we say normally about the renal diet for the patient that's in chronic kidney disease? High potassium or low potassium? Low, because they're going to run a high potassium. So low potassium. What about phosphorus? Or for your chronic renal patient, high or low in their diet?
Low.
Low. Remember, they're the ones that we give that Foslow to every time they eat a meal. And that just helps you remember it. Hey, I got to give them phosphorus reducing medications every time. This is your chronic person, so don't get confused on, okay, what's happening here? Is it a chronic issue? Is it an acute issue? Why do you think they need high protein for the acute issue? Isn't there some kind of damage or injury or healing or something that has to go on? So again, recognize what's happening with the patient, and again, potassium restrictions are usually needed, especially in the beginning, because the potassium is going to go up. So if in your story the potassium is 5.7, don't say I'm going to give them more potassium. That's too high. And you got to recognize that as soon as you see the numbers and what the lab values are for that patient. So here we are, identify the cause and treat the cause. Here's our chronic kidney disease, 5 stages. Lots of people have that. What's our risk factors? Hypertension, diabetes are the main risk factors. Somebody having acute kidney injury could put them into chronic renal disease if they don't recover from it. Diabetes is the leading cause, hypertension second cause. So again, recognize people that we take care of every day will probably have hypertension and diabetes, many of them in their diagnosis list of things that are wrong. What do we say about glomerulonephritis? What's our biggest concern? What's the vital sign we're monitoring the closest when they have glomerulonephritis? Heart rate, blood pressure, temperature. What's going to be in your answer that's going to be the most important thing? Blood pressure. Blood pressure. What do we say happens with glomerulonephritis? Inside of the glomerulus, it's the patient, there's infection going on. It makes the patient retain lots of fluid. It makes the blood pressure go up. What are some of the signs and symptoms of glomerulonephritis versus the patient just having an UTI? Hypertension is different. Their blood pressure's up. They have edema. Remember we talked about edema, their face and around their eyes. Edema, lots of swelling. Hot. They might have a high temperature, but is that my priority vital sign? No. Remember, look at the blood pressure. What do we have to give them if they have an infection inside their kidney, inside their glomerulus? Blood pressure meds. Look for an answer that you're saying to yourself, hypertension is the biggest concern I have with this disorder. Yes, I'm going to give them antibiotics, but if I don't get their blood pressure down, they could potentially have a stroke and that blood pressure be really high. So put those two things together with glomerulonephritis. Check the blood pressure. Check if they have proteins in their urine. Give them blood pressure medication. Yes, control the infection, but that makes it a little bit worse for that patient than just the UTI. Here's our nephrotoxic medications. We talked about myosin drugs and NSAIDs. Renal artery stenosis. What the heck do you think that means? What did I just say supplies our kidneys? Our renal arteries. What's renal artery stenosis? Narrowing of that artery. Makes sense, right? That now that artery that normally supplies our kidneys is not functioning. How could that get stenosed? There could be a stone there.
It probably could be from the blood being
Starts with a P. We have it throughout our body, peripheral, vascular disease, peripheral artery disease, right? Couldn't that affect our renal artery? It doesn't just affect our heart, it can affect everywhere where we have arteries in our body. Peripheral artery disease, okay, we all think, okay, it's the feet, right? We're gonna look at their feet. But think about a person who has peripheral artery disease and now it's affected their renal artery. What's happened to the flow to their kidney? It's decreased because there's stenosis there. So what, do you think we can fix that overnight? No. So now what will we possibly have to do? Sometimes they have surgical procedures, just like they do for your heart, to try to open up that artery to get blood flow to their kidney. Many times it's medication. Couldn't we change their diet and try to reduce their peripheral artery and getting any worse, their PAD getting any worse? So you have to think, our peripheral artery disease affects everything. Cirrhosis of the liver, we know what that is. Or recurrent infections. Keep having UTIs and nephritis and polynephritis over and over and over again to come down the kidneys. So our chronic kidney disease, we need to recognize on this slide what the patient's gonna look like, right? We talked about this. Halitosis could be there, that's bad breath. The patient can have dry skin, that's pruritus, they're gonna have itching. Think about good skin care for them, that's your select all apply. They yawn a lot, they're lethargic, they're anemic, they're tired, they have peripheral edema, they need to be on a heart monitor. This is your picture of your chronic renal patient. Thin, fragile bones, decreased skin turgor. And then I showed you a picture of that uremic frost that the patient sometimes gets, where there are lots of uremic things, urea is building up in their skin. And it's high numbers, right? Kidneys aren't getting rid of it like they normally should in this patient who's itchy and has this frost. It's almost like a white coating on their skin. Okay, again, may not have symptoms till later on. There's 5 stages. About stage 3 is when we start thinking about how are we going to diagnose this patient. We're not going to fix the issue, but we want to keep it from getting worse. What's our gold standard? And AV fistula, pick that every time. That's what we want to have in the patient. Here's your creatinine. Can go up pretty darn high. It can double in just a matter of 24 hours, 48 hours. BUN gradually goes up. Usually, creatinine goes up quicker. So we have to know normal numbers or we won't ever be able to recognize in our story. There's that sodium polystyrene that we were just talking about. That's K-exolate. Your story may not say K-exolate, right? Aaron, wake up. What could I give my patient for anemia, erythropoietin, epogen, to stimulate red blood cells? Pick that. Now you really do give that in real life. Ferrous sulfate, take that. Iron, that's iron. What are we going to tell our patient that's taking iron? Take it with vitamin C, right? Remember, that's what we take it with. What about their stools? We got to remember that they're going to be black and tarry. That's okay. Keep taking your iron. What lab value are we going to look at if the patient's taking iron? H&H, right? Makes sense. That's what it's going to affect. It's going to help our H&H build up by taking iron. Anybody on your phone, you probably should get off of your phone. Not a good idea. All right, so what do we say about antacids? Don't take the antacids that have what in them? Magnesium. So don't pick that because they can't get rid of magnesium. I'm trying to help you remember these things. Everybody needs to pay attention because this could be the question you get on NCLEX. Right? It's February. Wake up. Get off your phones. Because when you get to NCLEX, it might be the one question that you get wrong that might help you pass this test. You're only going to get 75 questions. And so here's Lasix. What's another loop diuretic? Starts with a B. Bumex. What's the name for Bumex? It's going to say bumetadine or bumetadine or something like that. That's Bumex. That's a loop diuretic. What do we know about them? Do they raise potassium or lower potassium? Lower. Right? So these don't change. Categories of meds will stay the same, and that's how you're going to be able to recognize meds when you see them. Here's our nursing care. This is important because this is your select all that apply. What am I doing for my renal patient? Obviously, monitoring vital signs. Weigh them every day. 1 kilogram is 1 liter of fluid. That doesn't change. How often, what are we going to report? How much weight would we report? More than 2 pounds in a day? Is that, is it, or what is it? I always get mixed up on this.
1 week and 3.
More than 3 in a week, isn't
Yeah, more
it?
than 3 in a week.
1 in a day.
2 in
Okay, so more than 1 pound in a day, 3 pounds in a week. That's utopia. That's what ATI tells us. Pick that if that's your answer. So more than 1 pound in a day, 3 pounds in a week. If you recognize that the patient lost 1 kilogram since yesterday, what does that mean? We removed 1 liter of fluid about that. And so 1 to 1 is kind of how I was, it's easier for me to remember it that way. What are we doing for this patient for their diet? High in carbs, remember? When they are waiting for dialysis and we're not dialyzing them yet, what about our protein, high or low? They have chronic kidney disease. Low, why? Because they can't clear protein. Everybody with me? Once they start dialysis and we're doing that for them, now we can increase their protein because the dialysis is helping get rid of that protein. That makes sense? This patient, rest periods for them because they're tired easily and they're anemic. Skincare is important because they have dry skin. Monitor their lungs because they end up with fluid buildup. And this is what happens to your renal patient. They get short of breath, crackles in their lungs. They're waiting for dialysis on Monday morning. I talked about it on Sunday night. We're giving them medicine if they're having trouble breathing. Again, health promotion, drink at least 3 liters of water a day. Why? Again, be very careful. Sometimes patients are on fluid restrictions. Sometimes it's okay for them to have fluid. So be aware what normally happens with your patient. And again, it'll be dietary driven, doctor order, okay, fluid restriction as needed. They'll order how much? 1,500 mLs a day. Or they could say, encourage PO intake, okay, because the patient needs that fluid to flush out the kidneys. Every patient's a little bit different. Reinforced teaching about the meds, get their albumin checked. What's normal albumin, and what does albumin indicate to us? Nutrition, our nutritional status, how we're using protein to build up our body. What's normal numbers for, same as potassium. No, same as potassium. Just remember, if I know what potassium is, I know what albumin is. So if my albumin level's low, what's that telling me? The patient does not have good nutrition. They're not eating well. They're not processing things. They're the hospice patient that we were talking about. You know, that's in seasons that their albumin level continues to keep dropping. And obviously limit NSAIDs. Don't administer myosin drugs. Amphotericin. Anybody ever heard of that medication? Amphotericin B is an antibiotic. It's in the aminoglycoside category. It is damaging to your kidneys. So many of the myosin drugs are damaging, NSAIDs, and then amphotericin. It's an antibiotic. And then, of course, remember, contrast diet. That's always going to be something that could potentially be nephrotoxic, meaning again, here's our kidney. So here's our care. Calcium carbonate, we would pick that if we see that on NCLEX or in real life. What does that do? Binds with phosphorus. The other name I told you was called Foslo. That's usually the brand name or the generic name of it. But calcium carbonate is the same exact thing. That's okay. Pick that. That is medication that removes the extra phosphorus. Take it with meals. Every single time the patient eats, take that medication. And then again, no antacids with magnesium, no NSAIDs. That's all your select oral clots. So here's our GFR. Here's our stages, 1, 2, 3, 4, 5. You can see how our GFR is going down. As we go all the way down below 15, we're in end-stage renal failure. We're starting dialysis. We may need a kidney transplant, or the patient's sick enough, they may decide it's just palliative care. We cannot fix it at this point, depending on what other things are going on or what other issues the patient has, or how old they are. Again, by this point, maybe we can't fix all the stages. We're going to try to slow it down up here. We got to recognize what are we going to do to obviously stop this stage of controlling blood pressure, monitor blood sugar, stop smoking, exercise, diet, and sodium medication. None of that changes. So here's all of our stages. And then here are some high phosphorus foods and low phosphorus foods. So we're going to recommend to them eat these low phosphorus things because your kidneys aren't working to help get rid of this inflammation. And these are just kind of explaining the signs and symptoms a little bit more. And then dealing with uremia. A lot of times these patients sleep a lot during the day, but they're awake at night. And then here's your numbers for different labs. And now we'll talk about prostate problems. So if somebody has an enlarged prostate, what could that create acute renal issues? Yes. Where does that fall in those categories? Post-renal, because the prostate is after the kidneys, right? It's going to affect something later on in our anatomy. That's where the kidneys are working. Fewer than 50% of men with BPH have severe enough symptoms. So how do their symptoms start? What is BPH? Let's start there. Benign prostatic hypertrophy or hyperplasia means the same exact thing. You might see it written either way. Enlarged prostate. Does that mean that the person has prostate cancer? No. The word benign alone should tell you it's not cancerous. Now, can people have prostate cancer? Yes. Can they have BPH and prostate cancer? Yes, they can. But if your reason for your enlargement does not always have to be cancer. It could just be that it's a male patient over 50, 60, 70, 75 that now has an enlarged prostate. What's your med that you're going to pick? Have you guys seen this come up in a question about somebody with BPH? What's the med that helps them pee, increases their fluid flow? Anybody see any question about tamsulosin come up or Flomax? Yeah, any question come up about that yet? Okay, that's your med. Tamsulosin is the name of it. That's your male patient that has trouble with BPH. We put them on this med. They take it every single day, and they probably take it every day forever now because they have an enlarged prostate, and it helps increase the urine flow so that it doesn't back up. Because what's going to happen if they don't pee and the urine backs up and stays in their bladder? UTIs. Could they get septic? Yes. With repeated UTIs, could they get polynephritis? Yes, they could. With repeated UTIs, couldn't it affect their glomerular bodies and then get glomerulonephritis? Yes, they can. There's your risk factor. Could repeated UTIs create chronic kidney disease? Yes, it can. So don't forget that that's part of what we're trying to prevent. So BPH is an enlarged prostate. It's benign. How do we know it's benign? How would we know it's cancerous or benign prostate problems? Biopsy, right? We're going to remove a sample from that prostate. Anybody heard of a PSA level? That's a prostate-specific antigen. People that have prostate cancer have an elevated PSA. What kind of exam is a physician going to do for a male patient to determine that their prostate is enlarged? How are they going to know from the outside, or what kind of physical exam are they going to do? Digital rectal exam. Yeah, that's what they do. They do a digital rectal exam, and the doctor can palpate the prostate if it's enlarged. It should not be palpable or whatever. You should not be able to feel it. So there's a couple different things. How do we diagnose an enlarged prostate? Exam in the physician's office, and this is recommended. I think it's after age 50. Again, we're talking about a male patient because female patients don't have prostates. So don't put your female patient on tamsulosin all the time. That's your male patient. Your female patient doesn't need a digital rectal exam. That's your male patient. We're looking for an enlarged prostate. So here's our symptoms, and these are the symptoms that the patient will tell you. And again, look at this first line. Many patients with this don't even have symptoms. Again, it's usually kind of once that prostate gets large enough to create these symptoms, this is what they're going to say. Most of the time, one of the first symptoms is inability to start her stream of urine or dribbling. What the heck does that even mean? That means the male patient who does not have a good urine stream. And when they go to the bathroom, they're standing there waiting, and a little bit is dribbling out. That's what the prostate patient usually looks like. Nocturia, what does that mean? They're getting up at nighttime because their bladder's not emptying, and then they stand there and can't empty their bladder. So they have hesitancy, that's a word that you might see come up. That means that even though they're standing there and trying to pee, they can't go. So they feel like they need to go, but they can't empty their bladder because the prostate is enlarged and doesn't let the urine come through the urethra. Right? Does that make sense? So what else happens? What are the symptoms? Well, they're straining when they're trying to urinate. They have all of a sudden they feel that sudden urge when the bladder gets so overfull. Slowed or delayed urination, painful urination. There's the word dysuria. You know what that word means. What's the word for bloody urine? Hematuria. What's the word for pissing urine? Pyuria. Now we know all those words. So this is your symptoms of your BPH patient because they have an enlarged prostate and they can't empty their bladder and things are not flowing through like they should. We're not always sure why. Again, 50% of men over age 50, 60% over 60 don't remember these numbers. It doesn't matter. You're never going to get the statistics number on NCLEX. But look, lots of men have this issue as they age. That's the bottom line. So pick that medication, cancelers, and Flomax is the other name. That's what you're going to give them almost all the time. How do we prevent this? Not 100% sure. Drinking extra fluid, the prostate, just by age alone, starts to develop and get larger. Again, it's not always the patient's fault. There's nothing that we can say they did wrong or right. But here's our symptoms again. And then here's our procedure that we're going to do to try to fix this problem. It's called a TURP, T-U-R-P. What does it stand for? Transurethral resection of the prostate. What the heck does that mean? That means we go in and we remove part of that enlarged prostate. The physician removes this surgically. Now again, this has developed to be a lot less, I don't know what the word is, barbaric than it used to be, but they still enter through the male's patient through the penis, and they go in with a scope and remove part of the prostate. So again, imagine the picture of this. Not the most pleasant procedure, but in order for them to pee and they're getting recurrent UTIs, what can possibly happen if they keep getting UTIs? Couldn't they get uroseptic? Yeah. Couldn't they get really, really sick? If a male patient deals with this for months and months and it's not getting better, we don't have an option. Right? You've been on antibiotics now 4 times in the last year because your prostate's so large, we got to fix this. So it's called transurethral resection of the prostate. What happens is they go in with a scope, remove part of the prostate. They typically leave a Foley catheter in that does bladder irrigation. So it's one of those 3-way catheters. You remember us talking about that, where one of the ports we infuse saline. So this would be your patient that has a Foley catheter that has 1 balloon port, and 1 port where we're putting in constant normal saline, irrigating that bladder, allowing it to heal in that area, and then take the Foley catheter out after a few days. What do you think their urine's going to look like in the first couple days? Do you think it's going to be a little bloody? Would that be okay? Wouldn't we expect it to be a little bloody? Didn't we just do surgery on your prostate? What is the point of us doing this continual bladder irrigation? To try to keep clots from forming in there, because if clots form, then what's going to happen? The patient's going to not be able to do what? Pee anymore. So the Foley catheter is continuous bladder irrigation. It's called CBI, if you see that written, or you might be doing it one day for a patient. All that means is we're doing continuous bladder irrigation. So if that's in your question, and I'm trying to make it as simple as possible, if that's in your question that the patient had a TURP, we're getting continuous bladder irrigation, and we're infusing over the next 8 hours 500 mLs, right? We're putting 500 in from the bladder irrigation. We emptied 1,000 from the Foley catheter bag. How much urine did the patient produce? 500. Everybody with me? You understand what I mean? That intake is 500 that we're putting in. 1,000 comes out. It doesn't mean the patient voided 1,000. What 500 of it is what we put in that's coming right back out. And so you have to recognize, if your question talks about this, deduct how much you're putting in from the amount that the patient put out. Now, would it be okay for this, for the first couple days, for the urine to be bloody, and you tell the patient, yes, your urine's gonna be bloody for a few days? If they go home and 3 or 4 days later, it's bright red blood, would we expect that? No. So you're gonna get bloody urine for the first couple days. You could, I've had patients with discontinued bladder irrigation where we have an order from the doctor, you have to have an order that you can irrigate that catheter if there's a clot. Because think about what happens if you have, male patient has surgery to their prostate and there's lots of bleeding and clots that form around that. Couldn't that affect their urine flow as they're healing? So that's what the bladder irrigation is for, to keep everything flowing through and healing, and then after 4, 5, 7 days, they take it out. So again, what is it? Surgical procedure involves removing part of the prostate gland. It's often used. What's that?
I'm just trying to find out, if someone's been here about it, and she went with the state court on Friday. And now, with the day court.
I did hear that third hand. It wasn't me, but I did kind of hear what happened, so I can talk about that.
Okay.
Yep. I did not hear, but I did hear information about it.
And if it involves on the student,
I'll go talk to them.
and the person.
Yep. I don't know if the student heard it though. That's the issue.
Okay.
Right. But I'll find out. Yep. So a TURP, surgical procedure, again, we're involved in removing part of the prostate gland because the patient has BPH and they can't pass their urine. So here's, just the picture alone says out, right? This is a metal scope. Again, it's small. It's not like a big metal rod. But again, it has to go through the penis and down here, and there's the prostate. You can see how this prostate is enlarged. It's going to prevent the flow of urine out the urethra. Does that make sense? That's what you're looking at when the patient has BPH. So by putting them on flow mats, it increases the urine flow and decreases the size of the prostate. That's what flow mats does. What other kind of medication might the patient be on? Couldn't they have bladder spasms? Couldn't they be on something called oxybutynin? Have you seen that come up? Yeah, write that down. That's a med for bladder spasms. Why would this patient have bladder spasms? Because they can't empty their bladder because the prostate's preventing the urine from flowing out.
You said I need one.
Oxybutynin, OXY, I think. Has anybody seen that come up? Any question? BUNTIN. For bladder spasms. So again, I'm just trying to help you recognize what kind of meds might be what I'm picking on anybody. Or that story might say that the doctor recently prescribed oxybutynin. You should somehow in the back of your head, okay, I remember her talking about that, bladder spasms. What diagnosis would pertain to this medication? You're going to want to pick BPH, right? Or something to do with the urinary system. Everybody recognizes this is how we're going to get meds. Just basically recognizing I've heard of it, kind of remember a category that it might be in. Okay, what do I think? So don't pick hypertension because it doesn't have anything to do with that, right? Beta blockers, calcium channel blockers, that's the things like that's the categories of how you're going to get meds on these drugs. So here's your care for this patient that had a TURP procedure, transurethral, meaning we're going through the urethra and resecting the prostate, taking out part of the prostate. Monitor for bleeding. Persistent bright red blood does not clear with irrigation. Patient will have continuous bladder. What the heck does that mean? The patient in the first few days will have bloody urine. That's okay. When they go home, do you expect it to be kind of pink tinge for a few days? Yes, you do. Do you expect once they go home a week later to be peeing bright red blood through their penis? No. Now they're bleeding and there's an issue. So in the beginning, the catheter is there, bladder irrigation is happening. If it becomes obstructed, what are you going to do? This is your answer. Turn off the bladder irrigation. So if you're putting in, let's just say, the bladder irrigation is running at 100 mLs an hour into the bladder to irrigate it. And then when you go to empty the Foley, there's nothing in there. And the patient's saying, I'm in so much pain. What do you think has happened? You got 100 mLs an hour flowing into their bladder. You look at the Foley catheter bag, and nothing is in there for the last 4 hours. Doesn't it occur to you, where did it go? Right? What do you think has happened? It's clotted off. There's a clot there. The patient's uncomfortable. Their pain is worse. So this is part of your nursing assessment, right? What's our first step in the nursing process? Don't say give the patient medication because they have pain. Why isn't the Foley catheter draining to begin with, right? Isn't that part of your assessment? Who's going to see that if you're not the nurse paying attention to it? Nobody. So just be thinking, okay, I've got this patient on bladder irrigation and it's going in, and I know that 300 mLs went in. Where did it go if it's not coming back out? There's a clot. This is what you can do with an order. Disconnect where the irrigation is going in and irrigate slowly. You're never going to be like, push in as hard as you can, right? I've seen people try to do that. I've seen people try to do that with NG tubes, and what happens? They squirt everywhere. Irrigate with 50 mLs. Do you think it's going to be sterile saline that we use, or just some tap water sitting at the bedside?
Sterile.
Sterile. Somebody please tell me sterile, right? Don't just grab some water sitting there. Oh, let me borrow your cup of water. I'm not going to squirt that into your bladder. I'm going to use sterile saline, irrigate it, and now you're hopefully going to get that clot to dislodge, and then that clot, now the urine comes out. Everybody with me? This is bladder irrigation 101. Now again, you're probably going to be working on a urology floor if you're doing this. Most of the time, these patients that have had surgery will come back to a urology floor or Christiana or wherever. Again, could you get somebody long-term care that's been at Christiana for 3 or 4 days and still has this hooked up? Yes, you could. So you have to recognize that I might be taking care of this patient one day. When a patient has a Foley catheter in, what happens? What's our answer if they say they feel the need to pee? Is that normal for them to feel the need to pee if they have a catheter? Yeah, people that have a Foley catheter in will tell you, I feel like I have to pee. What are you going to say? No, you don't. Yes, they do. They feel like they got to pee. What do you say? Okay, just go ahead and try to go like you normally would. Isn't it going to go into the bag? Yes. So tell them, okay, it's normal for you to feel this sensation. We got a catheter that's stuck into your urethra. How do you think it's going to make you? It's going to make you feel sometimes like you have to pee. That's normal. So again, client, with this irrigation going in, lots of times these patients would always tell us, oh, I feel like I have to pee all the time. We probably do feel like we have to pee all the time because we are putting in fluid and it's coming back out. Again, avoid kinks in the tubing. This is your transurethral patient. Avoid lifting, straining, strenuous exercise. Sexual intercourse up to 6 weeks is a no because they have to heal. Makes sense, right? It's all in the same area. This has to heal before any of this other stuff can happen. So no lifting. Why no lifting or strenuous exercise? What needs to happen with the prostate? It's got to heal. We just took out part of it. It's got to heal. Drink lots of water. Yes. Why? Because we want their bladder to be irrigated and keep things flowing through. Why no NSAIDs? Well, there it is. Increases the risk for bleeding. We've been talking about this for a long time. What else stimulates our bladder? Caffeine and alcohol. So what should they not do? Don't drink those things. So this is an important slide. This is your select all that apply if your patient had a TURP or needed continuous bladder irrigation or had some kind of procedure with their bladder. These are the things that we would be doing. This specifically for your patient with the TURP. And again, they're going to stay in the hospital for a couple days. They are going to go home now. Guess what? After 2 days in the hospital, they're going to go home with this Foley in. They're probably going to have BNA come to their house. What are we going to be teaching this patient? We're going to, sometimes some family member has to be there, be present, or the patient themselves to understand this bladder irrigation. If I put in 500, at least 500 should come back out. More than that, because I'm making urine, but I got to get out what I put in. Everybody with me? This is what we have to be telling our patient or educating our patient. Again, catheters usually have to place 24 to 48 hours. Now remember, there are much better procedures for this now than when I was at the bedside. This, again, a lot of men did not want to have this done for obvious reasons. But if they weren't able to pee, the doctor said, hey, you need to have this done. But from what I have heard, TERP recovery is much better than it was and much quicker than it was years ago because the procedures are, there's different devices, I guess. I don't know exactly what they're doing, but I've heard from people that are in neurology now, okay, it's not as bad as it used to be, and the procedures are quicker. And again, that's just medicine as it gets better. So again, you're going to have a urinary catheter in place at least 24 to 48 hours or until the prostate declines and you're able to pee on your own. What happens, do you think, when we take out this catheter? How long do we have before we want to make sure the patient can pee on their own? We took the catheter out at 6 a.m. this morning before I left for night shift. How long do we have? What's the most that we have?
8 hours.
8 hours, remember? So when should they be peeing if we took a catheter out at 6 a.m.? Well, they're probably going to get up and pee within 3 or 4 hours. What could we do for them to stimulate them peeing? Couldn't we have them drink more fluids? Okay, drink some water, get up and walk around, right? Okay, can you try? Oh, I don't think I can go. I can give it a try because your prostate's still going to be a little bit swollen. What could happen if 8 hours later they still haven't peed? What would we probably have to do then?
Call the provider.
We might have to straight cath them or put it back in. And I've had to do that before because the patient 8 hours later still can't pee. What does that mean to me? The prostate's still enlarged and it hasn't really healed yet, so that irrigation or that fluid needs to go back in. Again, most of the time the patient can get up after 2 hours. There's going to be some blood in their urine. That's okay. We don't want it to get any worse, and if your urine is obstructed and you're not able to pee, when you get home, what are we going to tell them? Call your doctor. Why? Because there's some kind of clot there, and it's not wouldn't be normal for them to say, hey, I haven't peed in 2 days. And their bladder is going to completely fill up, and bladders can rupture. And then you got another big problem, right? The bladder can only hold so much. So again, these are part of education of what you're going to be telling your patient when you go home. Again, your doctor's going to recommend you drink plenty of water to flush out your bladder. Why would we want to avoid constipation? Put 2 and 2 together. What's happening if they're constipated? They're straining. So what are you going to tell them to eat? High fiber. There it is. And you're saying, put it all together in your head, right? If they're constipated and they're straining, isn't that going to put more pressure on that prostate that's trying to heal? Yes. So make sure sometimes, and many times, these people get put on stool softeners. Pick that. Or they might, do you think they're going to get an enema to that area? No. So you're going to give them something by mouth, like a laxative, Dopalax, or mag citrate or something to help them go to the bathroom, avoid constipation. Wait to resume your blood thinning medications like Coumadin, right, until your doctor says it's okay. Wouldn't we hold those medications probably 5 or 7 days before we did this surgery? Yes, because the patient will bleed if their blood is too thin. Avoid strenuous activity. There it is. No lifting, no strenuous exercise, no sexual intercourse for up to 6 weeks. Don't you think it's important that we tell the male patient that ahead of time? They need to be aware of that. Oh, by the way, see you later. You're going home, but no sex for 6 weeks. What do you think they're going to say? What? No, so again, seriously. So this is stuff that they have to know ahead of time so that they're prepared for this and it's not life-changing to them. And nobody told me that part. Well, I'm telling you now, you're not going to be their favorite nurse when they're headed out the door. You wait until then. Avoid driving until your catheter is taken out. Call your doctor. Again, if you can't pee, that's important. There's a clot there. There's something there. If all of a sudden your urine looks like ketchup, this is what we tell people, it's too thick and bloody. If it's pink tinged and got a little bit of blood, it's okay. But if it's really thick and bloody, call your doctor. What does that mean? What would you tell them? Drink more fluids, notify your physician. Everybody with me? This is our instructions for this patient. And again, if they develop a fever. Why if they develop a fever? What's happened if they got a fever 24 to 48 hours? They got a UTI. Many times these patients are sent home on antibiotics anyway, just to prevent them from getting UTI. So again, normal prostate looks like this. Your urethra's open and flowing. This is a male patient. This is what BPH looks like. You can see how it constricts the urethra and the patient can't pee. What does that Flomax do? It decreases the swelling and opens up that urethra. That's the purpose of the Flomax. What's the oxybutynin do? It's for the bladder spasms that the patient has. So again, here's our effects. It's not cancerous, so it's not life-threatening unless the patient gets septic. It's inconvenient, it's uncomfortable. Again, think about their quality of life. And again, this is a physician and patient-made decision. When is it time for me to think about having this surgery? How is it diagnosed? Well, their questionnaire, what kind of symptoms? Well, I noticed for the last 3 years, I can't pee like I used to. Or when I go to the bathroom, I have stand there and they're not going to say I have hesitancy. They're going to say I just can't go. Or I notice that it's dribbling and it's not a good stream of urine. So these are your symptoms. There's your digital rectal exam that the physician is doing. Ultrasound of the prostate might be done. We're going to get a urine sample. What are we going to expect the urine sample to have possibly in it? What's a normal urine look like? Because we just had that on our summative packet here. No bacteria, no red blood cells, no white blood cells. What do you think this person's urine looks like? Probably has some red blood cells. Probably has some white blood cells. It could be cloudy, right? Think about what's happening. Their urine flow is not clear and not good like that. And again, the urine flow rate is going to be down. So how is it treated? If they have mild symptoms, medication. If it gets worse and it's affecting their quality of life and their ability to empty their bladder, now we have to do surgery. Okay, so we don't go to surgery first, we find medications. There are some shock treatments now, and again, that's what I'm saying. I've heard of newer things that are out, like almost like breaking up the kidney stones. They have different procedures now that can help reduce the swelling in their prostate without doing surgery. So again, a urologist would know all these different procedures. We don't need to know them because we're not performing urology surgery in here, but we need to recognize that there's better options for this patient. Here's our PSA. If the patient has prostate cancer, it's going to be greater than 10. Recognize that a PSA is what indicates cancer. This person with BPH may not have an elevated PSA because they don't have cancer. So what is a PSA? What's that stand for? Prostate specific antigen. That's what PSA stands for. And that's usually elevated when the patient has cancer. How do we know for sure if it's cancer or not? Biopsy. Do a biopsy of the prostate. And then we can tell, well, there's no cancerous cells, we just have an enlarged prostate. Now we need to do this procedure. There's that perf going in through the penis and into the prostate, removing part of that tissue and taking that out and reducing the swelling that's down there. All right, so there's one thing that happens, and this is just a quick complication, not a quick complication, it's a complication. What happens? When we're doing bladder irrigation, there's something called TERP syndrome. I think it only happens, I don't know, I think it's less than 10% of the time. I think it says it on here. Yep, 1 to 8%. Okay, what happens? When we're doing bladder irrigation, in a nutshell, if we're putting in large amounts and it goes at 200 mLs an hour, isn't that a lot of flow going into our bladder quickly? What happens with TERP? The patient is unable to process all that extra fluid, and it causes, remember how we said how fluid can shift from inside your vascular space into your tissues? It's almost like that disequilibrium syndrome for the dialysis patient, right? Same kind of principles. This person getting this continuous bladder irrigation is getting the irrigation too quickly, and their body starts absorbing it. And what symptoms they have is because they become overloaded too quickly. Does that make sense? I'm trying to make this as simple as possible because this TERP syndrome is something I didn't understand for a long time, and it only happens less than 10% of the time. But what is happening? Intravascular volume shifts because of the extra fluid that we're giving them. What do you think our answer would be if the patient starts developing confusion and seizures and fluid overload? What would we do with this bladder irrigation? Stop it. At the very least, decrease the rate. Notify the physician. So again, all I want you to recognize from TERP syndrome, look through the slides here. What's our option? We need to recognize it and catch it early. Look how quickly it can happen. Can occur as soon as 15 minutes after they got out of the OR, or up to 24 hours. So in the first day is when this is most likely to happen. It's called TERP syndrome. The volume that they're getting is too much for their body to handle. So they become overloaded with too much fluid. And I think there's this, again, what happens, notify, so the people that are a higher risk to have this happen is the patient that has been in the OR for 6 or 8 or 10 hours. The prostate was so large and the doctor had to do surgery. And so basically the longer time frame for the surgery, the more likely this is to happen in a nutshell. Because they're in there for such a long period of time. If it's a quick procedure and the patient's prostate and they were able to remove part of it and get to that section of the prostate in an hour or two, no big deal. But we were always taught, if you're taking care of somebody post-TERP, and they'll say the OR time is 8 or 10 hours, more likely to develop this, because the longer the surgery goes, the more irrigation they need, the more likely they're going to develop too much volume. Does that make sense? So the shorter time frame for the surgery, and again, it just depends on the surgeon. How large is that prostate? How long has this been going on? Is this years and years and years, and the prostate is so big that the surgery is needed in 6 or 8 hours? Does that make sense?
So can you remove the whole prostate?
They usually only take out part of it. Some of it needs to usually left behind that creates hormones for the male patient. Right? So again, all TERP syndrome is usually in the first day. These are the key points. The patient develops signs of circulatory overload. What do we say happens to your brain if you have too much fluid in your brain? Doesn't it swell? Don't they get signs and symptoms? Couldn't they have seizures? Couldn't they have headaches? What do you think happens with their blood pressure if circulatory overload goes up? Right? Everybody with me? This is fluid volume overload, not deficit overload. So again, there's some factors that increase it. We'll talk about what TERP is. Let's find our slide that has our signs and symptoms of TERP syndrome. There it is. Classic triad of features. What the heck does that mean? That means 3 things that are most likely to happen. And again, remember, this can be as soon as 15 minutes after the surgery. So what if again, you're not going to get somebody, I could send 15 minutes after surgery, right? Just depending on where you might be working one day. But couldn't you be taking care of them within the first 24 hours with this bladder irrigation? So here's what happens. Their blood pressure goes up, their heart rate goes down, and they have change in mental status because they have too much fluid in their system. Okay, these are your 3 things that happen most often. This is our treatment. What are we going to do? We're going to slow down the bladder irrigation or stop it. We're going to notify the doctor. Wouldn't we want to give meds to get their blood pressure down? So could you take calcium channel blockers or beta blockers or vasodilators? Yes, that's okay, because their blood pressure is now 190 over 110. That's too high. Their heart rate's going to be low, and they're going to have signs and symptoms of mental status changes. What kind of med could we give to help get rid of the swelling in their brain? It's a diuretic. We could pick Lasix, but what's the other one? It starts at mannitol, osmotrol. Everybody remember that one? That's for extra fluid in our brain. Okay. So could we pick that for this patient? Yes, we could, because they have too much volume happening in it, and it can be an emergency situation because they're absorbing too quickly too much fluid. So again, treat mild symptoms. Again, you might give them Lasix. Severe symptoms, now we might have to give them that osmotrol. We're certainly going to slow down that fluid. So here's our treatment. If this happens, okay, notify the doctor. If this is starting to happen during surgery, they're going to stop the surgery and allow the patient's vital signs to stabilize before they keep going. We're going to make sure they have oxygen, because remember, they're in overload and too much oxygen, their oxygen level might drop. Restrict fluid. They might have bradycardia. Usually they have hypertension, and again, they might end up needing to be in an ICU for a day or two when this happens. So read through these slides. Don't get yourself caught up in studying this for days and days and days, okay? This is just a complication. Just want you to recognize that it's there. It can occur usually within the first day, most of the time, that's when it's gonna happen. And then here's your church syndrome signs and symptoms kind of listed here: agitation, confusion. 3 things that happen. This is a key point about it. Blood pressure goes up, heart rate goes down, some kind of mental status change. So your patient that was awake, alert, and oriented 2 hours ago, and all of a sudden they're sleepy or they're agitated or they're confused, and their blood pressure is 180 over 100, and they're getting bladder irrigation, you should be thinking, okay, what's happening here? Something is going wrong. They're probably absorbing too much too quick. Okay, we talked about some different medications for a patient that has prostate issues. Again, this is just describing TRP syndrome and what we would do. And that's the end of this. Okay, everybody good? Everybody okay with BP